What is going on, everyone? This is Dr. Josh Funk, and you are listening to the Strength and Knowledge Podcast.
Good morning, everybody. This is Dr. Zach Baker of Rehab to Perform and R2P Academy, and on this episode of the Strength and Knowledge Podcast, we have one of our two sports residents on with us, Dr. Abbey Hammann, who is here to talk to us a little bit about the shoulder and the elbow. So, Abbey, if you don't mind giving the listeners the article that you chose to go into for this month. I understand it is on throwing-related injuries, which is the topic that we were discussing last week. And this one's a little bit more geared towards the elbow with throwing injuries. So what do you got for us?
So today I kind of wanted to talk about a clinical viewpoint that I found. The article looks at the internal brace repair of the UCL, which is a newer procedure compared to the traditional UCL reconstruction in throwing athletes.
Awesome. So for anybody that has worked with the throwing population, we know that the shoulder and the elbow goes through a tremendous amount of stress with this, pretty unnatural and violent motion of throwing. One of the common injuries that we see, unfortunately, are UCL injuries. And oftentimes this is the dreaded Tommy John procedure that they need to get done. This has been around for a while. They've been doing UCL repairs for quite a long time. They have a general idea of what the return to play time frame is, what the return to play success rates are. But recently they've started this new procedure where they utilize the internal brace. This article does a good job of just looking back and seeing when we compare overall success rates, meaning are they returning to play, what are the differences between the more traditional method versus the internal bracing method. And when we look at overall time frames with returning to sport, what does that look like with the traditional versus the internal brace? So Abbey, talk to us a little bit just in regards to what they were looking at to gather their data for this.
So the American Sports Medicine Institute was the one that kind of developed this clinical commentary, and they were looking at that time frame that you just mentioned for the traditional UCL reconstruction. They estimated those cohorts were about 12 to 18 months of total rehab to return to their prior level of function, prior level of sport, whereas the UCL with repair and internal brace returned in about that 6 to 7 month time frame on average.
So that's pretty wild. That is a reduction almost to half, and in some cases a third of the amount of time. You're talking about traditional could be upwards of 18 months, whereas with the internal brace, that could be as short as 6 months. That is night and day. And if you're talking to somebody who is in a competitive sport environment, the difference between having a fall injury and being able to compete in the spring season and not missing any time compared to potentially being out for 18 months, which means if you tear it at the beginning of your season, you're missing not only that year, but the following year. I mean, that is a game changer. What did they end up finding when they were looking at the overall return to play success rates? When we look at the previous UCL surgery, was it successful? Were they able to get people back? And then when we look at the more internal bracing approach, what did they find with that in regards to getting people back to playing and level of play?
So with the reconstruction, it was reported that about 85 to 90% were returning to the same level of play, whereas the internal brace also looked at higher level of competition. So not only are we returning to the same level we were before, but are we able to be in a higher competitive range? And that percentage was around 90 to 95%. So either way, most individuals were returning to sport, but with the internal brace, there was a higher success percentage associated with that compared to that of the reconstruction.
Good. And I think one thing that's important to note with this is that both procedures have a pretty darn good success rate. I mean, with the traditional approach, they're still getting 85 to 90% of their people back returning to play. With the internal brace, now we're moving up to that 90 to even above 90% returning. And I think what's even more important to note is there's a difference between returning to play and returning to play at your previous state. And I think there's a variety of ways that you can look at that, and there's different ways that I have seen that voiced in various literature with regards to the throwing population. So whether they're looking at UCL injuries, whether it's more of your rotator cuff and labrum repair, oftentimes returning to play just means you go back to competitive baseball again. Returning to play at your previous state, that's defined different ways in different studies, but common ways that you will hear that referenced is the look at total innings pitched. So prior to injury, what was your average number of innings pitched in a given season, and did you return to that on the back end? Meaning, if you're somebody who is a starter and you usually started 15 to 20 games and would throw 6 to 7 innings per start, if you're not doing that following the surgery, that's not returning to the same style of play as you were before. Sometimes they look at it as pitch velocity. So if you're somebody who threw in the low 90s prior to surgery, were you returning to velocities consistent with that post-surgery? So there's a variety of different ways that you may see that reference, but oftentimes it either has to do with overall pitching velocity, pitching innings, or they may look at longevity of career, and they'll look at, does somebody return and they're just kind of there for one more year, or are they there for multiple years? And different studies will have different outcomes that they're looking for, and some may be a little bit more appropriate to look at than others. But that is something to keep in mind. Just because somebody returns to competition does not mean that they're returning at the same level of competition as before. So that's another metric that you want to look at. Now, Abbey, did they go, for those that are unfamiliar with what the internal brace is, did they talk at all about what that actually means? When somebody has a traditional UCL versus the UCL with the internal brace, what is that surgical approach, or what are they doing to create that internal brace?
So for this surgical approach, they did an ulnar nerve transposition, so kind of moved it out of the way in order to kind of defer the chance of having ulnar nerve neuritis. And then additionally, they were using a specific type of internal brace. So they were using a collagen dip fiber tape augmentation, which is kind of a newer intervention for the surgical approach. And they mainly use that in their overhead throwing athletes. So individuals that weren't necessarily receiving the surgery to go back to a primarily overhead sport weren't using that type of augmentation.
Perfect. And I think the presence of that ulnar nerve transposition, and whether it's there or whether it has not performed, is something that if you're encountering these individuals, whether it is a traditional UCL or the internal brace approach, is important to note, because there's a lot of post-operative symptoms that can mimic one another. Some of it can just be general flexor mass irritation. Some of it can be that ulnar nerve neuritis, and some of it can be just general inflammation of the medial elbow. Having a good understanding of what was actually performed is going to allow you on the back end to be able to better differential diagnose, and more importantly, provide prognostics for your patient in regards to, is this just something that's to be expected in the initial weeks following the surgery, or if it may present as more muscular in nature, does that correlate with your progression of exercises that you're doing? Or is this not supposed to be there and it's a little bit of a red flag and we should be reaching out to the orthopedic and seeing if they want to have a follow-up with this patient to make sure that everything from a surgical integrity standpoint is going well?
Yeah, and to kind of bounce off that, and kind of going more into like some of that eligibility. So another thing to consider, if someone's getting the internal brace, we're assuming that it's a partial tear of otherwise healthy tissue, or it's maybe an end avulsion of the UCL. So individuals that get repairs are not going to be those that have a chronic UCL insufficiency or have any like adaptive changes to the ligament as well. So I feel like that's something for clinicians to consider during the rehabilitation process, is that tissue is otherwise healthy if they're getting the internal brace repair.
Perfect. And those are guidelines that are helpful to be familiar with from a clinical side when I field questions from individuals. So maybe they're in the pre-operative phase and they're going back and forth with their surgeon trying to figure out what is the most appropriate one for them. Those are different things that I'll communicate to them that are part of the decision-making process. but I'll always tell them, defer to what your surgeon thinks is best, and make sure that they are well aware of what the different options are and the criteria that lead to them. Now, Abbey, looking at this kind of clinical commentary, it's pretty evident with the traditional approach versus the internal bracing approach, both get good results with regards to return to play. However, the internal brace does get athletes back at a higher percentage. They are performing largely at the same competition level that they were pre-surgery with the internal brace. And they're also coming back at a much more accelerated time frame with the internal brace. What are just some general limitations or things to consider, though, for anybody who's looking into this article?
So for me, the biggest things that I was thinking about as far as what limited information I had was for these surgical participants, what were the ages that were involved, what were the genders, in addition to what overhead sport they were potentially playing, if position that they were playing in their sport was a factor, and the level of competition they were playing at. Are they a high school athlete that doesn't intend to play on a club or competitive team? Are they trying to go and play in college or eventually go pro? So those were all considerations I was kind of thinking about as I was going through the article, because there weren't any specific mentions of the patient population. So it listed about 527 surgeries, I believe, but it didn't list the participants. It didn't list any attributes about them.
And I think another important thing to keep in mind, if we bring this back to a more clinical context, whether we have a 12 to 18 month rehab or a 6 to 7 month rehab, the sequence of events that we care about from a PT standpoint are going to look very similar. The time frames at which we spend in each one of those sequences or phases of rehab will definitively differ between the two different approaches. But in the beginning, we're still in our very acute postoperative healing phase. How much precautions, how many contraindications we have in that phase are going to be dictated by the type of procedure that was done, but we still care about the same stuff. We want to get swelling out of there. We want to protect the surgical site. We want to keep symptom levels as low and appropriately low as possible. And then we want to start beginning to rework in just general muscle activation and range of motion within whichever precautions they have. As we transition into that next phase, now symptoms are under control. We're able to start moving the affected joint and some of the adjacent joints a little bit more. We really want to start optimizing movement. But depending on what type of procedure was done, we still may have definitive restrictions in regards to positional stresses that are either creating valgus stress at the elbow, and that may be due to direction of force or just joint positioning of the elbow, shoulder, and wrist. And we may have some general resistance limitations as well. Moving into the next phase is really when we get into strength building. We've got symptoms under control. We've optimized movement. Now we need to optimize movement with some degree of intent. And whether that intent is moving as much force as possible or moving a set rate of force at a higher velocity, that's kind of where we go in that strength building phase. Then we move into sport specificity. And this is really where a lot of the variance occurs with these two different protocols, because one, you're going to have a much later entry point into throwing, and you're going to have a much longer adaptation phase for that tissue to acclimate to throwing demands, whereas the other one is more training volume dictated. They're able to tolerate it. It's just they haven't thrown for a little bit of time, and we need to reintroduce them at an appropriate rate. So I think with this, something to keep in mind is that from start to finish, the actual rehab protocols look relatively similar. Just the amount of time that you're staying in each phase is going to be different. And more importantly, your criteria for progression into the next phase is much different. One is based more off of biological healing timeframes and medical contraindications, whereas the other one is more functionally based. Abbey, any other just parting thoughts or conclusions that you have from this article?
This article kind of gave us an outline of postoperative care, so kind of to bounce off what you were just talking about, they look very similar. That first month is almost identical between the internal brace repair compared to the reconstruction, and that kind of length of time is just getting lengthened over time. As far as the reconstruction is going to be a longer process, it's going to look the same, it's just stretched out more, whereas the repair is going to be similar, just kind of crunched into a shorter amount of time. I think big thing is to consider is the UCL repair with the internal brace is newer, so clinicians might start to see it a little bit more. And keep in mind that if patients aren't completing rehab within that 7 months, that's not the end of the world. That's more the average. So I think this article is great to kind of have a viewpoint and have kind of a set amount of time that we can educate patients on what we can expect their rehab time to look like, but it's not necessarily going to be the end-all be-all. But I think it's super helpful for patient education as well.
Yeah, and I think I love that you hit on expectations. And one of the first conversations you should have with somebody when they're coming in postoperatively for an evaluation is, what has been verbalized and communicated to you by your orthopedic? Have they given you any expectations with regards to returning to play, what that looks like, how long that's going to take? And then that allows you to get on the front end and be very proactive with your communication as well and make sure everybody's on the same page. Another thing that comes to mind with this study also is not every orthopedic does the internal bracing procedure. And the ones that I have encountered doing it are ones that work with high-level athletes. So they are working with the professional population, they're working with the collegiate population, or they're working with the high school population that has very high prospects moving forward. And they are voluntarily traveling and seeking out an orthopedic who does this procedure. So when we look at those accelerated rehab timeframes, some of those can be attributed to surgical technique and the surgical process. Some of that also may very well be we're looking at a population of people that has significantly different resources than the general population. And if you are a high school athlete who is getting the more traditional approach done, you're going to a relatively traditional outpatient experience. You're going twice, maybe 3 times a week. You're not working with a strength conditioning coach outside. Really, your whole rehab is confined to what you're doing at PT. That's not what's happening with the professional athlete who's getting the internal brace done. They're going to have care 7 days a week. They're going to be getting treatment twice, maybe 3 times a day. They're going to have a medical staff. They're going to have athletic trainers. They're going to have PTs. They're going to have massage therapists. They're going to have any resource they want readily available, which is also going to help accelerate that recovery process as well. So keep in mind, as you alluded to, the type of patient population you are working with may have an influence on overall rehab timeframes as well. So Abbey, as always, appreciate you coming on here, diving into the literature. I put this article in the category of a very good summative piece of literature for people to become familiar with the 2 different types of UCL surgeries that can occur. And I would encourage everyone, if they work with this population, to get more familiar with the internal bracing procedure, as you may see that happening more often in the future. Abbey, thank you for your time.
Thank you for listening to the Strength and Knowledge Podcast. If you enjoyed this episode or have been tuned in for multiple episodes, we would love for you to subscribe, rate, and give us a review on Apple Podcast or Spotify. Until next time, thanks for listening.